Good evening, I'm Dr. Oak and we are meeting again in this channel, Critical Care Basics. We are running ECG tutorial in this channel and this is the 29th ECG tutorial when we are talking about supraventricular tachycardias, part 1. This tutorial is on focal atrial tachycardia. So let's begin. Tachyarrhythmias are defined as abnormal heart rhythms with a ventricular rate of more than 100 beats per minute. So, any tachycardia, the heart rate has to be above 100. Secondly, to call it tachycardia, there should be at least 3 to 5 beats of fast rhythm. For example, patient is in a sinus rhythm of say 70-80 per minute and suddenly he develops paroxysmal tachycardia. So, if he develops 2 fast beats, then it is called as couplets, 3 or more, then it is called as tachycardia, right? If it is lasting more than 30 seconds, that is called as sustained tachycardia. Like we discussed just now, if the abrupt onset and offset is there, that is called as paroxysmal tachycardia. And incessant or permanent, when it occurs most of the time and is annoying perseverance. Right, so it remains with the patient most of the time and is symptomatic. So patient is, bugged by this tachycardia. Then it is called persistent or incessant tachycardia. And when this incessant tachycardia occurs on a long-term basis, then this is called as chronic tachycardia. Tachycardias are basically divided into 2 main categories depending on the QRS duration. So if the QRS duration is less than 3 small squares or less than 120 milliseconds, then these are called narrow complex tachycardias. Narrow complex tachycardia means that the rhythm, the sinus beat or the impulse is passing faster and reaching the ventricles faster, causing a rapid depolarization. That means that the current is passing through the conduction system of the heart, that is the SA node, AV node, the bundle of his right bundle and the left bundle branch, Purkinje fibers. So that means the current travels fast and depolarization happens fast. That is why the QRS is narrow. So ventricular depolarization takes less than 120 milliseconds. While ventricular tachycardias or wide complex tachycardias usually arise from the ventricle, although there are exceptions to this rule. The wide complex tachycardia means the complex is wide because the complex is not traveling through the normal conduction pathway, or the conduction pathway is partially blocked, or there is some aberrant conduction. For example, in this monophasic ventricular tachycardia, this is an example of monophasic ventricular tachycardia. The current is passing not through the conduction system, but from cell to cell. So naturally, the depolarization is taking a lot of time, and the tachycardia is wide QRS tachycardia. So, in other words, if the QRS is narrow, we can conclude that the rhythm is coming from above the bundle of his, right? If the tachycardia is wide, it could be originating from the ventricle or it could be originating above the ventricle but passing through the ventricle with some aberration. Supraventricular tachycardia or SVT is the tachycardia with atrial or ventricular rates more than 100 beats per minute. Just listen to this again. The ventricular rate can be less than 100, but it still could be supraventricular tachycardia if the atrial rate is fast. So supraventricular tachycardia means atrial and or ventricular rate faster than 100 beats per minute. And the mechanism of the tachycardia, the origin is either in the bundle of his or above, that is in the SA node or AV node. Traditionally, SVT includes all kinds of tachycardia apart from the ventricular tachycardia and atrial fibrillation. Atrial fibrillation naturally originates from the atria, but surprisingly, either because of an irregular rhythm, this is conventionally not considered as a part of supraventricular tachycardia. So supraventricular tachycardia includes all the rhythms which start from the SA node and the atria, AV node and the bundle of his with a ventricular rate or atrial rate more than 100 beats per minute. So the narrow complex tachycardias could arise from the atria, like if they arise from the sinus node, that will be sinus tachycardia. It could be inappropriate sinus tachycardia. We have already seen a lecture on this. My previous videos, the link is given below. Sinoatrial reentrant tachycardia, again we have discussed this, the link is given below. Intraatrial reentrant tachycardia and atrial tachycardia, this is what we are going to discuss today. Multifocal or multifocal reentrant or multifocal atrial tachycardia, this is slightly different from the atrial tachycardia, we'll discuss it later. Atrial flutter and atrial fibrillation, we are going to discuss separately. Narrow QRS tachycardia could arise from the AV junction, like AV nodal reentrant tachycardia, AV-NRT, or atrioventricular reentrant tachycardia, AV-RT. Then junctional tachycardia, junctional ectopic tachycardia, and non-paroxysmal junctional tachycardia. So today we are going to discuss focal atrial tachycardia. Atrial tachycardia or focal atrial tachycardia is a regular atrial rhythm at a constant rate of more than 100 beats per minute, originating in the atria but not in the sinus node, apart from the sinus node. Focal AT is also called as atrial ectopic tachycardia because it is an ectopic rhythm not arising from the sinus node, usually arises from a single site, in contrast to multifocal atrial tachycardia within the left or right atrium. In contrast to macroventricular atrial arrhythmias like atrial flutter. Atrial flutter is a macro re-entry tachycardia, while this is a single point tachycardia generation. And atrial fibrillation, atrial fibrillation has many re-entry circuits and many foci developing arrhythmia at the same time. So unlike this, focal atrial tachycardia usually arises from a single discrete ectopic focus. In atrial flutter, for example, there is a macro re-entry. So there is a big re-entry circuit, while focal atrial tachycardia usually arises from a specific point apart from the sinus node. Focal atrial tachycardia has a rate of more than 250 beats per minute, although it can be less than 200. And importantly, there is isoelectric interval between the P waves. For example, here you can notice there is a PQRST and there is no this type of flutter wave. You can see the clear P waves. This is the P wave, P wave, P wave, and the rate is there are almost two big blocks or big squares. So the rate is 300 divided by 2, around 150 per minute, the ventricular rate. And you can see it is a regular tachycardia, no irregularity, and the shape of P is slightly different from the P wave of the sinus node. How can you say that? Because here in this script you have not taken the sinus node ECG. This is a known patient of focal atrial tachycardia. So you cannot distinguish that P wave from the sinus P wave. But if you have a one strip showing sinus tachycardia as well as focal atrial tachycardia, then the P waves arising from the focal atrial tachycardia will be different because it is an ectopic focus. Atrial tachycardias are least frequent form of supraventricular tachycardias. Atrial activation occurs from a discrete focus, usually less than 2 cm in diameter, with a centrifugal spread. This definition is as per the Heart Rhythm Society. Mechanisms could be abnormal automaticity, triggered activity, and micro re-entry. We have taken 3 independent videos on three mechanisms separately. So the link is given below. Kindly go through the link and see those videos to understand these mechanisms. And importantly, this is not usually associated with the underlying heart disease. This is unlike MAT. MAT, multifocal atrial tachycardia, is usually associated with pulmonary disease, right? And the prognosis is benign unless tachycardia-induced cardiomyopathy occurs. If the tachycardia is continuous or incessant, causing decreased LV function or LV failure, then it is called tachycardia related cardiomyopathy. Except that consequence, usually this is a benign problem. The site of origin is more often from the right side, less often from the left side. On the right side, in the right atrium, the most common site is the tricuspid annulus, and the second is crista terminalis. In the left atrium, most common site is focus around the pulmonary veins, 67%. Other sites are less common. Associated conditions. Most commonly, focal atrial tachycardia occurs in absence of the heart disease and generally is benign. We have discussed this point. Focal atrial tachycardia may occur in patients with organic heart disease in response to atrial stretch. So if there is any cause or any problem which causes a stretch on the atria, this can give rise to focal atrial tachycardia due to elevated atrial pressure in conditions such as hypertension and cardiomyopathy. In addition, chronic heart disease AT can also be associated with acute events like myocardial infarction, pulmonary decompensation, infection, excessive alcohol, hypokalemia, hypoxia, cocaine, and theophylline, especially in bronchial asthma patients. What is incessant atrial tachycardia? The term incessant is applied when the atrial tachycardia is present for 90% of the time is the patient, whenever the patient is monitored. Number one. This is often found in otherwise normal young individuals, including children, although it may occur in patients with organic heart disease. So, unlike what we expect, this is also found in people with structurally normal heart and even young people. The rate tends to be faster during the day than during the night, and it increases with exercise or pregnancy. Incessant atrial tachycardia may be responsible for tachycardia mediated cardiomyopathy, which refers to left ventricular chamber dilatation, systolic dysfunction, and the patient can present with left ventricular failure, which is caused by persistent tachyarrhythmias. Especially those focal arrhythmias which occur from the atrial appendages and the pulmonary veins cause these incessant tachycardias. Another category is post-atrial fibrillation ablation. So the incidence of atrial tachycardia appears to be higher among patients who have undergone catheter ablation for atrial fibrillation. The post-AF ablation ATs are often incessant. They are associated with rapid ventricular rates and respond poorly to pharmacological measures. So we have to ablate them as well, and the ablation is also difficult. About digitalis toxicity. In patients who are taking digitalis, toxicity should be suspected when a new atrial tachycardia is seen, especially if it is combined with 2:1 or higher grade AV block. We have yet to discuss AV blocks, but 2:1 AV blocks means if the atrial rate is 200, the ventricular rate will be half, that is 100. So every alternate beat is conducted. So if there is a tachycardia which develops with AV block of 2:1 or higher in a patient taking digitalis, then you should strongly consider digitalis toxicity, and digitalis should be discontinued, and if the patient is hemodynamically unstable, consider giving anti-digitalis antibiotics. The clinical features of focal atrial tachycardia: palpitations. The abrupt onset of rapid fluttering sensation in the chest and neck is most consistent to tachyarrhythmia such as focal atrial tachycardia. Importantly, paroxysmal, so there is abrupt onset and termination. Patient with focal atrial tachycardia can present with syncope if the circulation to the brain is compromised, predominantly if the ventricular rates are high. Patients with other underlying cardiac comorbidities such as heart failure, angina can present with symptoms associated with the clinical condition, with worsening of their underlying disease, such as they can present with dyspnea or chest pain. How do we diagnose focal atrial tachycardia? The atrial rate, please pay attention, not necessarily the ventricular rate. Atrial rate during focal atrial tachycardia is generally between 110 and 120 beats per minute. There is classically distinct P waves and intervening isoelectric interval is seen. This is the difference between flutter. These are the P waves of flutter, and so this is a flutter with 3:1 conduction. While focal atrial tachycardia, the P waves, even if there is 3:1 conduction, the P waves will have intervening isoelectric interval. The P wave morphology can appear normal or abnormal depending on the site of origin. There is subtle difference in P waves from the sinus rhythm and the atrial tachycardia. So if you have a ECG, previous ECG of the patient in sinus rhythm, so that will be helpful. You have to specifically focus on lead V1 and lead 2. They are the most important in assessing the P waves. Negative positive biphasic P wave in V1. What is the meaning of negative positive? Like initial negative and then positive. This is called as negative positive biphasic P wave in V1, and negative P wave in lead 1 suggests left atrial focus. So if the focus is in the left atrium, it will be negative positive P wave in V1. If P wave from the right PV foci are narrow and those from the left PV foci are broad and uniphasic. This is just to get an idea as to where the focus is. Coronary ostium produce P waves negative in the inferior leads and positive in AVL and AVR. Let's just see some examples. So, if the P wave in V1 is negative or biphasic with initial positive and terminal negative deflection, the AV focus is likely to be in the right atrium. So, this is the V1, you can see initial component is negative. You can see positive component in lead 2, positive P wave in lead 2. So this is right atrial focal tachycardia. Focus arising from superior crista terminalis. So crista terminalis is a ridge which joins the origin of insertion of the superior and inferior vena cava, and narrow complex tachycardia with uniform P waves consistent with atrial tachycardia originating from the crista terminalis. So see the positive P waves in V1 and also tall P waves in E2. Tachycardias with uniform P waves consistent with atrial tachycardia originating from the left superior pulmonary veins. P upright in V1. So whenever you have a focal atrial tachycardia, rhythm like focal atrial tachycardia, and P waves are upright in V1. So rhythm the focus could be in the left atrium. This is from the coronary ostium. P waves negative in inferior leads and positive in AVL and AVR. So P waves are negative in inferior leads and positive in AVL and AVR. So this is the likely focus is from the coronary sinus ostium. Another thing that we have to see in any tachycardia, supraventricular tachycardia, is whether it is a short RP interval or a long RP interval. Normally, the sinus tachycardia will look like this. The distance between the R and the following P will be larger or longer than 50% of the R interval, right? Or simply stated, the RP interval will be longer than the PR interval, right? So this is long RP interval and this is short RP interval. So if it is short RP interval, it is more likely, this supraventricular tachycardia is more likely to be atrioventricular reentrant tachycardia or AV node reentrant tachycardia. While if it is long RP tachycardia, it is more likely to be either sinus tachycardia or atrial tachycardia or atypical AVR NRT and some AVRTs. So then, if you have a narrow complex tachycardia with a QRS interval less than 120 milliseconds and heart rate more than 100, see for the long RP interval or short RP interval. So long RP interval will look like this and short RP interval will look like this. So if it is long RP interval, if you see sinus PV morphology, then it is more likely to be sinus tachycardia. If you see non-sinus PVO morphology, it is focal atrial tachycardia. While if it is short RP, then it is either EVRT or orthodromic reentrant tachycardia. What do we do in focal atrial tachycardia? I have just considered this topic in very brief because we just have to have a glimpse of how we treat these cases. Suppose a patient has focal atrial tachycardia, narrow QRS, fast tachycardia, regular. First thing is whether the patient is hemodynamically stable or unstable. If the patient is not hemodynamically stable, the BP is less, or patient is having sweating and patient is symptomatic and he is having altered mental sensorium, then you can try adenosine or you can directly cardiovert. So class 1 indication for cardioversion, class 2 indication for adenosine. If the patient is hemodynamically stable, are you convinced that this is focal atrial tachycardia? Diagnosis is certain? If no, give adenosine and see the result. If yes, then you can either try beta blocker or drcboak or verapamil, again class 1. If any of these is not successful, then IV amiodarone or IV pegmilide. Ongoing management of suspected atrial tachycardia. So if the patient is a catheter ablation candidate, that candidate who will require ablation because the patient is going in cardiomyopathy related to focal atrial tachycardia. In that case, you have to do ablation. Or some patients because of persistent symptoms, so they demand ablation, so they prefer ablation. In those candidates, you can directly go ahead with catheter ablation. The guideline is class 2. If you want to try drug, the therapy options are beta blockers, drcboak or verapamil, or flecainide, propafenone, or you can give amiodarone or sotalol. In case these options fail, then you again go to catheter ablation, and the success rate of catheter ablation is 40 to 90%. So that's all about focal atrial tachycardia. In next lecture, we'll discuss about atrial flutter. Thanks a lot. If you are liking these lectures, please subscribe, like and share.